Health Insurance Benefits Assistance Program, and today we're going to talk about the basics of Medicare, which we call Medicare 101. I'm going to walk you through some of the basic information, and then we're going to take a look at the individual components of Medicare. First off, I want to mention, just like a lot of other industries, Medicare does have an awful lot of acronyms. We affectionately call this alphabet soup. If you are in possession or have downloaded the PDF of our Oregon Guide to Medicare Insurance Plans, there is a reference to all of those acronyms on page 81 of the 2020 guide. If you haven't already done that, I recommend that you do get a copy of that either electronically or at your local SHIBA office if it's open. Because of the current situation, we may end up having to mail that to you to keep from having to come into the offices. But just know that we've got a lot of 3-letter and 4-letter acronyms, and it can get a little confusing. We like to say that we speak fluent Medicare, so sometimes it's helpful to have an interpreter. Today we're going to look at a little bit about what SHIBA is and what SHIBA does. It's kind of a nice acronym. It sounds like the Queens of Sheba, but actually it's SHIBA, Senior Health Insurance Benefits Assistance. And then we're going to jump into the basics of Medicare A and B. I call this original Medicare because original Medicare is what A and B started in 1965. After A and B got started, some additional insurances were offered, both private insurances that go along with Medicare and then additional insurances that contract with Medicare. So we're going to look at all those different types of insurances and how putting certain packages together might work better for some people and how going another direction might work better for others. Sprinkled throughout the whole presentation and then wrapped up at the end, we're going to talk about timelines. Timelines are really important in the Medicare world. If you miss a deadline, you may have a delay before you can make another choice. And if there is a prolonged period without coverage, you may end up incurring a late enrollment penalty. Late enrollment penalties obviously should be avoided at all costs because they generally do stay with you for the rest of your Medicare life. So understanding those timelines is critical, and SHIBA counselors can be very helpful in assessing when you need to do what to make sure that you are not late. I have a couple of slides at the very end. We have 2 very large retiree groups that we often serve. One is the PERS, public employees from Oregon, and the federal employees. So we have a couple of tips at the end for those folks, and then we'll wrap it up with some final thoughts before we say adieu. So what is SHIBA? Well, SHIBA actually has been around since about 1980 sometimes. It was a program that was funded by the federal government to help folks who are getting ready to come on Medicare understand the Medicare program, and if they have problems, they have an advocate that understands the program and could go to bat for them. We provide individual Medicare counseling and advocacy. All of our counselors are either volunteers or paid staff, and all of our services, whether it's a counseling session, somebody who's going to bat for you for an issue, or a free class, all of our services are free. And that is part of our grant requirements from the administration on community living. The other mandate we have with our grant is that we have to provide objective information. What does that mean? Well, that just means that we have to give you the full lay of the land and let you make your own decision. We are not allowed to make recommendations. However, we can help you analyze, oh, these are the pros and cons of this plan, and this is the pros and cons of going this direction, And then once you make your choice, we can help either point you in the right direction to a licensed insurance agent if that's what's required, or we can actually act as your typist and enroll you in your plan of choice using a publicly available website called Medicare.gov. If you have not been to Medicare.gov yet, that is a great website with a ton of information. I recommend all new to Medicare folks get familiar with that site and, if possible, set up a mymedicare.gov account. That is going to serve you well going into the future. We are available Monday through Friday, 8 a.m. to 5 p.m. local time in our call center. And pretty much all year long, we are helping folks that are new to Medicare. That's folks that are coming on to A and B for the very first time. And right now, we have between 10 and 11,000 people per day turning 65 in the United States. We affectionately call those baby boomers the silver tsunami. And so it does keep us on our toes, and we are pretty busy all year long. For folks who are already in Medicare, they have A and B, they might want to jump in, make a change, jump out to what's called Medicare Advantage or a prescription drug plan. We're going to talk more about those two items later, but during that time period, which is October 15th to December 7th of every year, folks who are in Medicare are allowed to make changes for the next calendar year. So it's kind of like when you're working and your employer says, oh, well, in the month of October, you got to decide what you're going to have for the next year. Same thing with Medicare. You get a chance every fall for about a 7-week period to review what's available and make your choice. If you are in a Medicare Advantage plan or you're in a drug plan and you do nothing, it will automatically roll over for the next year under most circumstances. From time to time, we do have plans that do decide they're not going to contract with Medicare, and then you'll get a notice that you have to make a different choice. We also developed a pretty nice website. It's called Medicare Starts at 65.oregon.gov. And again, this is tailored specifically for that baby boomer generation that's turning 65 right now. And there are a lot of great links on here, Medicare frequently asked questions. If you're getting ready to go have a one-on-one counselor appointment, you might want to bone up on some of the constructs of Medicare so that you know the questions to ask. But take a look at this website and get familiar with it. On the resources side, on the right-hand side, we have our toll-free statewide 800 line. Again, that is answered live Monday through Friday, 8 a.m. to 5 p.m. Right underneath that, we have our email address, shiba.oregon@oregon.gov, and we do answer those emails in real time. If it's a particularly thorny question and we need to do a little bit of research, it might take us a day or two, but usually we're pretty quick at answering those emails if we're not in a crunch time period. We've got Medicare counseling links there so you can see what your local office might be. And then we've got classes and other events that are posted. Right now, we're suspending all those events because of the current situation with COVID-19, but we hope to have those back online later on in the year. If you have friends or family that is not living in Oregon, but they would also benefit from having some advocacy or counseling regarding their Medicare, there is a link there that says Not from Oregon. And this program is present in all 50 states and 4 territories. So they may not be called SHIBA, but we're all part of a much larger national organization called the SHIP Network, S-H-I-P, with an emphasis on the end of that P for program. That stands for State Health Insurance Assistance Programs. And every state has a SHIP program, and they might have a different program name. In Oregon, Washington, and Idaho, it's the SHIBA program. In California, it's called the HICAP program. We're all a little envious. Alaska used to be SHIBA, but they're now the Medicare Information Center. So they actually get to have a name that says what we do. But we all talk fluent Medicare, and we are your local resource for timely and accurate Medicare information. You may know that there are no Medicare offices in every state. The closest Medicare office to Oregon is in Seattle, Washington. And that regional office handles all of Oregon, Washington, Idaho, and Alaska. So using your SHIBA connections is going to be your best bet for getting local information that is accurate. So we get teased often when we go up for our trainings. We go to CMS trainings regularly, and anytime we ask one of our trainers the answer to a question, they'll say, well, sometimes, maybe, and it depends. So depending on circumstances, that is probably the most important answer that you can give anybody until you know what the details are. Right now in our call center, our most frequent question is, I'm still working, and do I need to enroll in my Medicare? So, of course, the answer is it depends, because it depends on whether or not someone is covered by active work group health insurance. That is the one and only way that you can avoid enrolling in Medicare at age 65 without incurring a late enrollment penalty. I'm going to repeat that because this is a very important qualifier. You must be covered by active work group health insurance through your own work, or if you are married to somebody and they are covering you under their group health benefits through active work. That is the one and only way that you can avoid and delay enrolling in Medicare without a penalty. Now, I put a little tickler there that says not COBRA. COBRA is one of those potholes that folks step into and they don't even realize it. COBRA is after you have separated from your employer, and maybe your employer is paying for that insurance premium, and that coverage is just like it was when you were working. But guess what? Social Security does not recognize that as active work because it really is after you have stopped working. So COBRA will never, ever be primary if you are eligible for Medicare. Now, what happens if you get laid off and your employer says, oh, part of your severance package, you can have COBRA and we're going to pay the premiums for the first year? The first thing you want to do is, if you are age 65 or older, is go sign up for Medicare. Medicare will be primary and COBRA can be your secondary. And if your employer is willing to pay those insurance premiums, that's not such a bad deal. There are some hiccups though, so talk to your SHIBA counselor if you're in that situation, because after 1 year, if you decide that you need to go to some other insurance, you may have to go through medical underwriting, and we're going to talk about that later on. But COBRA is one of those things that we often see folks, they fall into that COBRA pothole and then it comes back to bite them later on, and we don't want you to get caught in that dilemma. I like to make a distinction between health insurance and health care. A lot of folks confuse the two. Health insurance pays the bills. Health insurance is what Medicare is. Health care is what you get at your local physician's office, clinic, hospital, etc. So when the health insurance program was first passed in legislation in 1965, it was specifically for people age 65 or older. And then a few years later, in 1972, Congress allowed folks who could not work because they had a disability and they had filed for Social Security disability. And in this country, most often, up until just recently, 2010, folks got their health insurance through their employers. So if you couldn't work and you couldn't get your health insurance through your employer, it was really important that this program was rolled out for those folks. So now we have people who are 65 or older and people under age 65 who have filed for Social Security disability that are eligible for the Medicare program. In order to start Medicare, you actually have to go through Social Security. Social Security is the enrolling agency, and they're the gatekeeper to that program because they're keeping track of how much you have earned over the course of your work life. If you've been married to somebody who is working and you are the stay-at-home spouse, you can collect on that person's work history if it's more than 10 years. How much did you pay into the system? Are you on time? What is your effective date? All these things are determined by Social Security. They do not, however, have any information on the benefits. Their only job is to determine if you're eligible and when that coverage is going to start. Once you're in the program, now your benefits are going to be administered by the Centers for Medicare and Medicaid Services. And between Social Security and CMS, those are probably your most common acronyms that you're going to see, SSA or CMS. On the right-hand side, on the bottom, is a sample of an old Medicare card. Take a look at that card. It has somebody's name, their Social Security number, their gender, a signature, and the date, the month, and the year that they turned 65 most often. Right there, that is an inherent fraud concern, because if somebody is carrying that card with them 24/7 and their wallet or their purse is stolen or lost, now somebody has their name, their signature, their Social Security number, and 31 days to choose from for the date of birth 65 years earlier. So that was a real risk factor, and we have between 60 and 90 billion dollars a year, billion with a B, 60 to 90 billion dollars a year in Medicare fraud. So we are here to tell you, be the eyes and ears and keep your card safe. We don't want you carrying that card with you 24/7. The good news is the Affordable Care Act in 2010 said, you know, we really need to do something about that old Medicare card. We're going to redesign it so that it's not as risky. So the new cards, which have all been distributed as of the end of 2018 and took effect January 1, 2020, don't have a signature, they don't have a gender, they don't have a Social Security number, they have what's called a Medicare Beneficiary ID. A Medicare Beneficiary ID is a computer random generated number, 11 characters long, alphanumeric, and it's specific to one person. This card looks like a pretty decent card, except I can tell that it's fraudulent right away because the start date for A and B says March 3rd. Medicare never starts on any other day but the first of the month. So in order to spot fakes, we would know immediately that that is not a legitimate Medicare card. There's some other things too. There are certain letters that will never be used because they look too much like numbers. So we've got some precautions in there and safeguards to keep people. But still, it's not a good idea to carry this card with you on a 24/7 basis. Put it in a safe place. If you need to use it, you can take it. If it's an emergency, you're going to get care anyway, so don't worry that you don't have your card with you. All right, in this first section, we're going to kind of give you the very highest 20,000-foot level. Medicare is broken up into 4 parts, and then there is a 5th independent part that's not on this slide. So Part A is hospital insurance. That is the only part of Medicare that is federally mandated through payroll taxes. As we work and we earn wages, we get taxed on those wages, and on your pay stub you'll see something that says FICA tax or Medicare tax. That's the part that you're paying into that Medicare Part A hospital program. So that when you get to be age 65, you've paid in enough so that you don't have to make a monthly premium. It does take a certain amount of contribution, so we'll get there when we get to the Part A in specific details. Part B, Part C, and Part D are all optional. They are not federally mandated through payroll taxes, so it is important that you know that if you want to have Part B, C, or D, you actually do have to take an action to enroll in those programs. Part A comes with your Social Security retirement benefits. Those two are tied together, but B, C, and D are all add-ons. B is the heavy lifter of the Medicare program. Medical insurance encompasses anything and everything you can think of other than the actual hospital facility. So physicians in and out of the hospital, emergency rooms, medical equipment, doctor's visits, physical therapy, all of those things that you would normally have in your regular visits to your medical. Hospitals are kind of infrequent, but regular medical visits are all going to be charged to that Medicare Part B. Medicare Part C came about in the early 90s, and it was a different way to deliver Medicare benefits because lots of folks had insurance companies that they had had with their employers their whole life. It was originally based on the Kaiser Permanente model. So if you were a Kaiser member and you aged into Medicare, you most likely wanted to stay with Kaiser because Kaiser doctors and Kaiser facilities were kind of all enclosed. And so Medicare said, okay, Kaiser and all of the other carriers like Kaiser, you can contract with us, and instead of getting the Medicare benefits claims sent to the federal government, you're going to take care of all those claims. So we have Medicare Advantage plans that are all the big players in Oregon. Think in terms of Kaiser, Moda, HealthNet, Providence, Atrio, AllCare, that we've got lots of choices, Regence, Blue Cross. They all contract with Medicare, and if you would like to have that insurance company managing all your benefits, you can, and we'll look at that at the very end of the presentation. The last thing that came on board legislatively in 2006 was the Part D prescription drug program. Up until 2006, folks who were on Medicare did not have coverage for the prescriptions that they purchased at their local pharmacy. Those are called self-administered drugs. There was drug coverage if you were an inpatient in the hospital, and there was a drug coverage if you wanted to go get a shot from your physician, like a flu shot or an infusion, but all of those self-administered drugs were out of pocket, and that was really starting to hit the bottom line for a lot of Medicare beneficiaries because those prescriptions were starting to cost more and more. So in 2006, Medicare added the Part D prescription drug plan, and it's been a very good program ever since, and we're going to take a deep dive into how that program works as well. So let's just look at 2 ways that you can build your package of Medicare benefits. Option 1 is the a la carte, or as I try to be funny and say, the Alucard method. You have your original Medicare card. A and B, and it is your primary insurance, and everything after that would be secondary. So A is for the hospital facility, B is for all the medical services you get, but it doesn't have drug coverage. So you might definitely want to add Part D prescription drug. Now, it is optional. If you don't want it, you don't have to take it, but there is a downside. If you don't take it now and you want to add it later on down the road and you don't have other prescription drug coverage, there might be a late enrollment penalty added. For folks who have other prescription drug coverage, like veterans, some veterans have drug coverage. Some folks have retiree plans that have drug coverage. As long as that prescription coverage is considered as good or better than what Medicare offers, you're golden. That term is creditable. And every year, your insurance, prescription drug insurance carrier needs to tell you whether or not that coverage meets or beats what Medicare offers, and the drug coverage is creditable. But for most people, they're going to want to have A, B, and D, even if it's just to stay out of that late enrollment penalty. And I'll show you some ways where you can get that drug coverage for free if you're not taking meds and you just want to avoid that late enrollment penalty. So we've got A and we've got B and we've got D, and some folks want to have some extra insurance because there are some out-of-pocket costs associated with A and B that could be surprising. So some folks might say, gee, I want to get a Medigap policy. That covers the 20% that is usually follows B. It covers both the deductibles for A and B. There's some extra days in the hospital or skilled rehab that might occur. So Medigap is a good way to offset those out-of-pocket costs so that you're not surprised with those bills. Folks who have retiree benefits from their employer might also have the similar option of a secondary insurance plan. PHIP stands for the PERS Health Insurance Program. It is one of the largest retiree groups in the state, and we do have PERS Health choices that we're going to look at the very end. In some cases, folks work for companies that have less than 20 employees. In that case, Medicare says to protect that small business from the exceptionally high cost of insuring older workers, they will take on primary coverage and the employer plan assumes secondary. So it's a good idea to know if you are working for a small employer, if that is your situation. If that is your situation, it's advised that you do enroll in A and B so that you have that 80% coverage. You're still protected. There's no late enrollment penalty, and you can enroll any time while you're working. But if your employer is a small employer, they're only going to pay as if you were enrolled in Medicare in that little portion, that 20% after the Medicare amount. And then we've got some other groups. Indian tribal members, they have Indian Health Services, and they may have specific tribal benefits that go along and work secondary to Medicare. And folks who may have lower incomes or qualify for the state Medicaid program, they're also going to assume secondary. Tribal benefits and Medicaid are considered the payers of last resort. So Medicare would always be primary, and those two would be secondary or last if there was more than one insurance plan. So you can see on this slide we have a Medicare card, A and B. We have a prescription drug plan all by itself, Part D. You have a separate card for that. And then you might have a third card that is your secondary insurance. So that's why I call this the Alucard method, which kind of goes along with the a la carte method, because it is picking and choosing how little or how much insurance you would like to have. The second way you can pull your package together is to get everything bundled together under one roof. So that is the Medicare Advantage plans, also called Medicare Part C. If you decide to stay or go with a, say, a Regence Blue Cross or a Providence Health or a MODA or Kaiser, Medicare actually pays those companies on a monthly basis for every member so that the federal government doesn't have to process claims. And that new company that you have enrolled in assumes primary position. So all your services, all of your claims, all your grievances and appeals, all of your prior authorizations, all of your prescriptions, everything, hospital, doctors, everything is going to go through that private insurance company that is contracted with Medicare. And these companies are setting a service area that is geographically specific. So in some areas we have Kaiser is available, in other areas Kaiser's not available. So they have a set geographic area where they serve, and they have developed all of their facilities and physicians and such. So if you live in the valley, you're going to have more options. As you get further away from the valley toward the coast or the eastern Oregon, you are going to have fewer options because those carriers have to develop a network of participating providers, hospitals, pharmacies, the whole shebang that is going to work for their members under that program. A and B at the bottom there are still your foundation. You have to be enrolled in both A and B in order to even be eligible to join a Medicare Advantage plan. If you were to ever lose that plan or leave that plan for whatever reason, you would go back to original Medicare unless you chose a different company to go with. So A and B is always going to be your foundation to fall back on, but once you become a member of that Medicare Advantage organization, now everything stays under that roof. So those are your two options, and this is a pretty important decision. This is the first decision point that you're going to need to make. Am I going to go down option one and pull together my package a la carte, or am I going to go down option two and I'm going to get all my benefits and services and providers through one organization? And it's real easy to go from option one to option two. It's not so easy and depends on timing if you want to leave option two and go back to a secondary insurance plan. You can always go back to Medicare, but you can't always get back into a secondary insurance plan. So this is an important consideration to make. So when we have folks that have retiree plans, they oftentimes will have managed care options as well. So on the PERS health insurance program, they have one Medicare supplement, also known as that Medigap policy, but they also have 4 different Medicare Advantage companies from which to choose. So if you are a PERS retiree, then timing is essential, and you want to check out your options under that program as well, or any other retiree program. We've got lots of university systems, we've got motor companies, we've got telecommunications companies, warehouser, timber companies. They all offer some type of retiree benefit. Okay, so now we're going to take some deep dives into the individual parts of Medicare so you understand how that part actually functions. Part A is that hospital insurance that is mandated through payroll taxes. When you work and you earn wages and you pay taxes on those wages, you are earning credits. It takes 40 credits to earn a Social Security retirement benefit. It also takes the same 40 credits to earn premium-free Part A. So that means that you're not going to have any monthly cost to you for that insurance program. That doesn't mean that you don't have some out-of-pocket costs. It just means that you don't have a monthly premium. How do you know whether or not you have the necessary credits? Well, Social Security sends out statements every 5 years if you're under age 50. And then I believe they start sending you statements every year. It may be age 60. Then they start sending you statements every year. And in that statement, there is a line item that says how many credits you've earned. If you know that you have earned enough credits for Social Security retirement benefits, then you have earned enough credits for Social Security premium-free Part A. If you didn't work, but you were married to somebody who did, if you are currently married, then you are golden. As long as your partner is at least age 62 or older. They have to be eligible for Social Security retirement, albeit early retirement, in order for you to collect on their work history. If you are divorced, you have to be married to that person for at least 10 years to claim that Part A premium-free under their work history. And it can't be two people that adds up to more than 10 years. It has to be one person for 10 or more years. So that was your work history to stay married to that person for 10 years. Folks who didn't have a work history or didn't have a spouse that they were married to with a work history can buy into Medicare Part A. It is pretty spendy. It's $458 per month in 2020. Now that is a specific group of people that they have an additional choice. If you don't have premium-free Part A, you can actually go look at the marketplace, and we can help with that as well if you want to give us a call if you're in that circumstance. Part A has a deductible of $1,408 each time you go into the hospital and you are admitted as an inpatient. It's not an annual deductible, it's called a benefit period deductible. And the difference is that that deductible can reoccur multiple times during the year. But there's an exception. If you are discharged from the hospital and you get readmitted to the hospital within 60 days, you don't pay that deductible again. You just pick up right where you left off. So Medicare's counting how many days you have been in the hospital, and after 60 days, now instead of no copay, because you had that deductible that's covering those first 60 days, now you're going to have a daily charge. And the daily charge does change from year to year. So we recommend that you look at the 2020 SHIBA guide for those daily charges if that is a circumstance that you would like to know more about. Once you are admitted to the hospital as an inpatient, Part A is very specific to that status. You have to be an inpatient in order to have Part A cover your hospital stay. Lots of people go to the hospital through the emergency room and they might be in observation for a while. That is not an inpatient stay. That would be covered under your medical benefits. But an inpatient stay is always going to be covered under Part A, and here's what it covers: room and board, general nursing, supplies, and medications. You don't see surgeons or anesthesiologists on that list, do you? This is insurance coverage for the actual facility, not for the services that go on by the physicians and providers in the facility. So they get billed separately to your medical side. Just the facility is billing to your Part A side. If you happen to be in the hospital as an inpatient status for more than 3 midnights, you now have access to an additional benefit called the skilled nursing benefit. Let's just say George is out in the orchard and he's up on the ladder and he falls and shatters his hip, God forbid. He goes to the hospital, he's admitted as an inpatient, and they say, yep, George, you really shattered your hip, you're going to be here for a while. We're going to have to take out all those bone fragments and give you a new hip. So he's in the hospital for probably 4 or 5 midnights, and then doctor and discharge planner comes and says, you know, George, we think you would really benefit if you went to go get some rehab. And we've got this skilled rehab center that's in your vicinity, and we could discharge you straight to that rehab place. George thinks that's a pretty good idea because he lives alone and he doesn't have anybody to care for him at home. So he gets to have 20 days at no additional cost where he's going to get all of his, you know, food and bedding and services plus additional physical therapy, occupational therapy, and whatever the physician orders. But George had to have that 3 or more qualifying inpatient stay in order for him to earn those additional benefits. If George needs more than 20 days of rehab, let's say he's bouncing back really well, but you know, it might be a good idea if he stays another 10 days. Now he's going to be there for 30 days. He has a daily charge from starting on day 21. And that daily charge is significantly discounted because skilled rehab can run anywhere from $300 to $500 or $600 a day, depending upon how much skilled therapy services someone needs. So $176 per day is the out-of-pocket cost, and then Medicare contributes to that additional charge for those physical therapy and services. Let's just say George says, no, I don't want to go to skilled rehab. I want to go home. Everybody wants to go home. They just can't wait to get out of the hospital and go home to recover. So yes, George can go home. Home health is also free of charge. There have to be certain circumstances present in order for that home health to kick in. Number 1, the physician has to order it. Number 2, George needs to need it. So he has to have the need for skilled services, either physical, occupational, speech, wound management. Some skilled services have to come in. Number 3, it has to be a Medicare contracted home health agency. And the last thing is George has a really hard time getting around all by himself. That's called homebound. He can leave home for religious services or doctor's appointments, but he generally needs assistance. He can't just hop in the car and run down to the casino for the day. So home health is optional as long as it's those 4 circumstances: physician ordered, skilled services, homebound, and a Medicare contracted agency. Let's just say George chooses home health when he first gets out of the hospital. 10 days later, he goes back to his doctor for his post-op, and he's not bouncing back very quick. And the doctor says, George, you know, if you had taken advantage of that skilled rehab stay, you really would have been bouncing back a whole lot quicker. Guess what? George still has that option on the table. For 30 days after he's discharged from the hospital, if his physician and George agree that he would do better in that skilled rehab facility, it's still on the table. Once 30 days has passed, now that benefit goes away and he doesn't have the option. So take a look at those benefits. If that's your circumstance, there are some good tools on Medicare.gov where you can find comparisons of different skilled rehab facilities, and Medicare does a really good job, I think, of letting the consumer know what the advantages and disadvantages are of different contracted agencies, skilled services. This Medicare Outpatient Observation Notice came about in, I think, 2016, 2017, because we were getting an awful lot of calls. Folks had gone to the hospital. Maybe they went in through the emergency room, and they were put in a hospital bed, but they were not admitted as an inpatient status. They were actually being observed, which is an outpatient status. And an outpatient status does not get charged to Part A, remember? So Part B is what covers outpatient status, and that's a 20% cost share. So 20% comes out of the Medicare person's pocket, and Medicare picks up 80% after the deductible. And sometimes that 20% can be a heck of a lot of money. So Medicare decided that we were getting so many calls of people being surprised by their medical bills that they are now requiring all hospitals to notify patients when they are in outpatient status instead of inpatient. So the rules just say if you're in a hospital bed and you are in that hospital bed for more than 24 hours, sometime between the 24th hour and the 36th hour, the hospital must notify you that your status is outpatient. And they actually make you sign a form. If you're not alert, conscious, and able to sign a form, they're going to notify somebody who is your representative, either a family member or caregiver. So Medicare outpatient observation notice is something that is commonplace now. Hospitals are very aware of this. My family member who had surgery last year got one when she ended up staying overnight a second night because she was in an outpatient status. I like to make this little joke too, that Medicare outpatient observation notice, the acronym is MOON, M-O-O-N. So the first thing that comes to my mind is when I'm in the hospital and I have a gown that opens in the back. That's the MOON notice. The second part of original Medicare is called Part B. Part B is your medical insurance, and as I mentioned earlier, this is the heavy lifter of the Medicare program. Now, this is optional. Folks do have to pay a monthly premium for this. If you don't jump in at the right time, you might incur a delay and an additional penalty amount that you pay. But for most people who are on time, starting in 2020, the premium is $144.60 if you pay it directly. If it's withheld from Social Security benefits, it's $145. Social Security always deals in round numbers, so they round up to the next dollar. It is income-based. So I like to tell a lot of my folks who are getting ready to retire, Social Security is going to base your Medicare Part B premium on your most recent tax return. Your most recent tax return most often includes your salary while you were still working. And so sometimes you'll get a notice that says, oh, you're not going to pay $145, you're actually going to pay a higher amount because your income as an individual was over $85,000 for that year that we're looking at. Double that if you're a couple. So instead of $85,000, if you're filing jointly as a couple, it has to be $170,000 and above. For most people, you know, they might want to file an exception because they don't want Social Security to base their premium on income that they no longer have. So talk to Social Security about their exceptions to that monthly premium if you feel that that situation is relevant to you. For most folks, the $144 is what they pay, or $145 I should say, and in addition to that monthly amount, there is an annual deductible. The annual deductible is just that. It is a true once a year, $198 this year deductible the first time you go get services. Once you meet that $198 deductible out of your pocket, Medicare starts contributing 80% to your medically necessary services. 20% comes out of your pocket. 20% doesn't sound too scary. When we're working, we oftentimes have insurance policies that expect us to pay 20%. The difference is my work coverage has what's called a maximum out-of-pocket. Once I reach a certain dollar amount, Now I don't have that 20%. But guess what? Medicare doesn't have a maximum. You're going to pay 20% whether it's $100, $1,000, or $100,000. So 20% gets real scary real fast when you have some really high cost medical services. And that's oftentimes what will tilt the scales for some folks to get either a secondary insurance that's going to pick up that 20%, or maybe they're going to go onto the Medicare Advantage side. That type of insurance does have a maximum out of pocket, so it protects people from financial risk. When we look at all the services that the Part B program covers, you can see it really is covering the vast majority of everything that we receive. Doctor services, whether that's in the doctor's office or whether it's in the surgical unit, emergency rooms, ambulance, which by the way is the #1 denied claim under the Medicare program. Ambulance rides must be for people who feel that it is life-threatening to travel in any other way to get to that hospital. So if it's something that is not life-threatening, be aware that you will probably be on the hook for that ambulance ride. Observation stays, like we talked about in the previous slide. If you're just spending the night or two and they're observing you while maybe some medical tests are being run, that is also going to be charged to Part B medical. Medical equipment. You know, folks, when they think medical equipment, they think wheelchairs and walkers. I'm thinking oxygen supplies and CPAP machines and nebulizers and insulin pumps and all kinds of things that you wouldn't normally associate. So all those medical equipments and supplies. Certainly lab tests, physical therapy, all of those services as well. So you can see why we often say Medicare Part B is the heavy lifter of the program. Now I'm happy to say that in 1965, preventive services weren't thought of very highly, but in the early 2000s, preventive services got a new look. And we had a wonderful hospital or Medicare administrator, Dr. Donald Berwick, who was a pediatrician by education, and he absolutely knew that preventive services were going to not only save the Medicare program money, but it was also going to result in better outcomes for Medicare beneficiaries. So we have a lot of preventive services now that are available to Medicare beneficiaries. One is called the Medicare Wellness Visit. You don't have any complaints. You just don't have a reason to go into the doctor other than you want to have a chat. And a wellness visit is one of those things that is free to the Medicare beneficiary that the doctor gets paid for. They can bill Medicare for it, but it's not something that you have to pay for. A wellness visit, however, is not a traditional physical. Traditional physicals still are not covered by Medicare, but wellness visits that encompass height, weight, body mass index, and blood pressure, that's the only hands-on that is included, also includes a conversation with a clinician, whether it's a physician, a physician's assistant, nurse practitioner, to talk about your risk factors. Do we need to have some cholesterol screening? Do we need to have your annual mammogram scheduled, or a PSA test? Or is it time for your colonoscopy? So lots of these things are silent killers, and if we didn't have screenings and get early intervention, it could turn into a crisis really fast. So take advantage of those preventive services, and just be aware Medicare is not going to pay for a physical, but they are going to pay for a wellness visit if you don't have any complaints and you want to just go in and have a chat with your clinician. Now, one thing that just happened this year, we got notice that on January 21st, Medicare was now going to start covering acupuncture specifically for low back pain. Traditionally, Medicare has not covered alternative therapies like naturopathy or acupuncture, but now because of the opioid epidemic, they're seeing the value in some of these more natural approaches. So if you have low back pain, you can have up to 12 acupuncture sessions in any given calendar year. If there is a medical necessity, you can have 8 additional up to a maximum of 20 per year, depending upon what your medical situation is. But just so you're aware that Medicare now covers acupuncture. I don't know how long it's going to take for acupuncturists to provide their credentialing or enroll in the Medicare program. Some Medicare Advantage plans have offered this service under their umbrella for some time. So their contracted providers would already be able to provide those services. Medicare might take a little bit longer since this is brand new, just was announced in January of 2020. But just keep that in mind. So I mentioned that annual physicals are not covered under Medicare, just the wellness visits. Other things that were not covered or considered medically necessary in 1965 was routine vision. So if you just want to go have your eyes checked and get an updated prescription for a new pair of glasses, that is not going to be a Medicare covered item. However, if you have medical issues of your eye, like cataracts, glaucoma, macular degeneration, retinopathy, any of those things that are medical in nature, Medicare does cover those because that is medically necessary. Dental care is kind of in the same boat. Dental care back in 1965 wasn't considered medically necessary. We know different now. We're hoping that at some point in the near future, we might start that conversation. I think Justice and Aging has already started that conversation about adding dental benefits to the Medicare program. But for right now, dental is going to be an out-of-pocket cost. I don't care where you see it. If you see anything that says Medicare covered dental benefits, it's as rare as hen's teeth. In the 15 years I've been with this program, I have never seen dental work covered by Medicare. Hearing aids are another spendy proposition. I think a starter set of digital hearing aids at Costco runs at about $2,600 and goes up from there depending on your deficits. Again, Medicare in its original form never considered that as being medically necessary. However, with all of these things, we do see now that there is a whole body impact. If you have poor oral health care, you might be subject to infections through your gums, or you might not be able to get your knee surgery or your heart surgery until you take care of your oral health. Hearing aids, if you don't have hearing that is compensated, we know that it tends to lead to early dementia. So all these things might eventually come onto the program, and it's going to take all our voices to get our U.S. congressional representatives to step up and make that happen. I make the not-so-funny observation that Medicare in its original form in 1965 really did not intend for our folks who were on Medicare to see, hear, or chew as they got older, but that is the sad reality. My only thought process there is that in 1965, the average lifespan for a guy was about 69, and for a gal it was 72. So they really didn't anticipate folks being on Medicare all that long. That last bullet, long-term custodial care, means that if you cannot take care of yourself in your own home, Medicare is not going to pay for someone to come in and care for you. They're not going to pay for you to go live in an assisted living community. They'll still cover your medical needs, but they're not going to take care of that custodial long-term care. That is going to either come out of your pocket, or if someone qualifies, they could have state assistance with that service or that long-term care placement in assisted living or adult foster care home. And we do have a wonderful program in Oregon called the ADRC of Oregon. It stands for the Aging Disability Resource Connection, and they have something called options counselors. If you contact your local ADRC about getting services to come into your home or talking about long-term care planning, they are going to be helpful to get you what you need. Whether you pay for it yourself or they will screen you for state assistance, that is a one-stop starting point for getting those benefits in action. Okay, so we've talked about Part A. It has a deductible of $1,408. We've talked about, and extra days if you're in the hospital for longer than 60 days or in the skilled nursing center for longer than 20 days. And we've talked about Part B. It has a $198 deductible, and it's got 20% with no limit. Starting to sound a little expensive and kind of scary. So the insurance industry saw a need to have folks have additional insurance so that they would not be surprised with those bills that they weren't anticipating. And this would be called Medicare supplement insurance. Supplement in the Medicare world is very specific. It means something that comes after Medicare. And the slang term for that same term, Medicare supplement insurance, is Medigap, because it picks up the gap between what Medicare says that it's the full amount, but they only pay a smaller amount. So there's a gap in how much is paid. So Medigap is always going to be secondary, and it's designed specifically to work with Medicare. It is sold by private insurance companies. There are about 40 different companies that sell Medigap insurance in Oregon. And the beauty about a Medigap is because it's secondary to Medicare, Medicare is national. You can go anywhere in the U.S. and the 4 territories and get Medicare services, and Medigap will follow wherever you go. If you're in Oregon and you're getting ready to buy one, you have to buy from a company that is licensed to sell in Oregon. So they are regulated by the Department of Insurance in Oregon, but they are federally standardized. That just means that the federal government said, we're going to make all the packages the same, no matter where you buy them in the United States. So everybody knows what each package includes. Let's take a look at what some of those packages might have. So 10 standardized policies in most states. Minnesota, Massachusetts, and Wisconsin are a little bit outliers, but for the most part, the rest of the states are all the same. And they're designated by letters of the alphabet, and I apologize, letters of the alphabet are confusing with the other parts of Medicare, but this is what they settled on. So each plan letter designates a specific package of benefits. Plan A has 4 items that would normally be out-of-pocket covered. Plan B has 5 items that would normally be out of your pocket covered. Plan G has everything covered except for the Part B deductible. And that is the most popular these days for new Medicare beneficiaries. There used to be a Plan F, but that's now only available to people who were on Medicare before 2020. It got phased out this year. But Plan G is exactly like an F, except that one Part B deductible is coming out of your pocket first, and then it kicks in for all of the other out-of-pocket costs. There are 10 to choose from, so this is kind of an exercise in study. What do I anticipate? What does my crystal ball say that I want to have as far as my coverage? How much financial contribution am I willing to put in to lower my premium? Because there is a reciprocal effect. The more you pay in premium, the more you get in coverage. The less you pay in premium, the less you get in coverage, and the more you're going to pay out of pocket. So for people who are very healthy and they have financial resources that say, well, gee, I can absorb that 20%, they might want to get a high deductible. For people who have lots of chronic conditions and they need to have full coverage, they might want to say, okay, I can budget a higher premium so I don't have any of those bills coming in out of my pocket. So it's good to compare. In our 2020 Oregon Guide to SHIBA, to Medicare Advantage, 2020 Medicare Guide to Medicare Insurance Plans, we have a list of all the companies. We have a list of their starting rates by age, and it does pay to compare those because each company can charge what their expenses and claims payout dictates. So there's something called a medical loss ratio, and the companies build their packages based on that loss ratio. So talk to your SHIBA counselor and get their input. They are very well informed and can help and even get some basic quotes from the various companies on your specific situation. But we are not licensed insurance agents. If you have a trusted trusted health insurance agent that you would like to work with, we are happy to give you some general information, and then you will go in better informed. Or if you would like to find a Medicare licensed agent in your area, we do have a search tool that we can direct you to for that as well. When you are considering buying a Medigap policy, you can buy a policy anytime. There's no open enrollment period specifically every year for Medigaps. What they do have is what's called guaranteed issue periods. Guaranteed issue periods are just what it says. You are guaranteed to get issued a policy. You're not going to be asked any medical questions. You're not going to have to disclose any pre-existing conditions. You are protected. And those time periods are specific. The first 6 months of your Part B, if you never started Part B while you were working and you worked until you were 70, and now you're going to jump into Medicare at age 70 and your B is starting for the first time, you have 6 months to choose a Medigap policy, and the company is required to issue you that policy. You are guaranteed issuance. If you got your B while you were still working and your 6 months has come and gone, but you had employer health insurance or some other coverage, maybe your spouse was working and they were covering you, if that employer group coverage or other coverage ends through no choice of yours, if you retire, your coverage generally goes with it. That's not a choice you're making. You do have an additional period called the 63-day guaranteed issue period. 63 days goes by pretty quick. We generally tell people, come see us before you retire so that we can, get your options on the table and you can pull whatever option you want immediately without having to vacillate. The third bullet there, within 12 months of enrolling in your first Medicare Advantage plan. So Medicare wants folks to have a chance to try something before they have to keep it. So if at age 65 you immediately enrolled in a Medicare Advantage plan, and maybe you got 10 or 11 months down the road and you said, gee, I really wish I would have chosen that Medicare supplement, Medigap policy instead. Medicare says, well, you have what's called a 12-month trial right. You get to try that plan for up to 12 months. But before the end of that 12th month, if you want to make a change, you have to let Medicare know. And you still have guaranteed issue into a Medigap policy. This only happens if you enrolled in a Medicare Advantage plan at age 65. It's not going to work if you retire at age 70 and enroll in a Medicare Advantage plan. I don't know why they made that rule, but that is the facts. Let's just say at age 70 and you chose a Medigap policy, and you've had that Medigap policy for 4 or 5 years, and it's starting to get a little spendy. And you see all these Medicare Advantage plans that are considerably less expensive, and you want to try one. Well, you're going to leave your Medigap policy to go try that Medicare Advantage plan for the first time. You still have that 12-month trial right. So I leave my Medigap, I go try this Medicare Advantage plan. Doesn't work out the way I hoped it would. I want my Medigap back. If I leave my Medicare Advantage within that 12 months, the company that I left for that Medigap has to take me back if they're still selling my policy. If they're not selling my policy anymore, then I can go to any company and get a Medigap policy. So lots of good protections there. The last bullet refers to something that is specific to Oregon only. And actually, I guess that's a little bit of a misnomer. We copied it from California, and it works really well for folks in Oregon. It's called the Oregon Birthday Rule, and it just means that if you are in a Medigap or you are a Medigap policy holder, and you've held that policy and it starts to creep up in price, and you see, hey, in the SHIBA guide, there are companies out there that are selling my policy, my exact plan letter. Remember, they're all exactly the same. My Plan G for a lot less money than what I'm paying per month. I have on my birthday and for 30 days following guaranteed issue to switch from my current company to a company that's offering the exact same plan letter, benefit package, or less benefits, and I have guaranteed issue. So I can say, hey, Company A, I don't want you anymore. Company B, I want you now, and I'm in my guaranteed issue period, and you have to write me a policy, and they do. So very, very good consumer protection in Oregon. Washington has something similar. It's not exactly a birthday rule, but they do have some consumer protections. So up and down the West Coast, we're very fortunate. Most of the rest of the states in the United States don't have those same protections. These are specific to individual states. They are not national protections. Oh, I throw these little things in there to make me remember. So if you are a PERS health insurance program member and you are within those group offerings, there is no medical underwriting any year you want to make a switch. So they have a plan change period every year. I believe it's October 1st through November 15th. And if you want to switch from Medicare Advantage plan to whatever's offered under the PERS program for supplement, or from supplement to the Medicare Advantage plan, that goes very smoothly. You just fill out the paperwork and it takes effect the next year. Talk to your PERS office if you need more information about that. There's lots of other insurance that works secondary to Medicare. We mentioned small employers. So employers that have less than 20 employees, for somebody who is at or over age 65. If somebody is on Medicare due to disability, that number goes up to 100 employees. So just keep that in mind. Lots of good retiree plans out there. There's so many that we can't be familiar with all of those. If you do want us to look at your retiree options compared to what's available on the public side, we would need to see a copy of your retiree policy information. For folks who have served our country and their career in the military, 20 or more years, and they have retiree benefits, that's called TRICARE. When you get to age 65, it converts to something called TRICARE for Life. TRICARE for Life is secondary to Medicare, so you must be enrolled in A and B for TRICARE for Life to maintain coverage. Same goes for CHAMP VA. CHAMP VA are the dependents and children of 100% disabled vets. CHAMP VA is also going to be secondary to Medicare. And Medicaid is the safety net, that is the state financial assistance program, and we're going to look at that next. So the national program is called the Medicare Savings Program. It is administered by the states, and there's some federal match dollars that come along with it, and each state sets its own eligibility criteria. In Oregon, if you are an individual with a gross income of $1,456 or less, then the state of Oregon, at the very least, is going to pay your Part B monthly premium. Part B is in boy, that $145 a month. If you're a couple, that amount goes up to $1,960 gross monthly. And oftentimes folks will ask me, well, what income do you count? Do you count my Social Security? Yes. Do you count any? It really goes by your tax returns if you file, or if you don't file, you need to have some statements either from Social Security if you have any dividends, et cetera, et cetera. We used to count savings accounts and other assets like vacation homes or property. And so in 2016, the state of Oregon said, no, we're not going to count those assets or resources anymore. So we had a lot of folks who maybe got turned away prior to 2016 and they never came back. So this may not affect you personally, but maybe you have somebody in your circle of influence, a friend, family, neighbor, who could really use a little extra financial assistance. Let them know that they can contact us, and we can screen them for this Medicare Savings Program and get that eligibility determination started. If you have income that is even lower than that $1,456 or $1,960, then the state of Oregon could possibly pay for not only the premiums, but also the out-of-pocket costs, the 20%, the extra days in the hospital, skilled nursing, the deductibles, et cetera. So it all depends on what that gross monthly income turns out to be. Okay, so we've talked about Part A, which is hospital. We've talked about Part B, and now we're going to talk about Part D, as in drug, the prescription drug program. Prescription drug insurance is optional, but again, it's a carrot and stick. You can choose not to have that Part D, but if some years down the road you get a prescription for a diagnosis and maybe it's kind of a spendy prescription, number one, you can't jump in the middle of the year. There are certain timelines when you can jump in. And number two, for any months that you did not have prescription drug coverage, you're going to start paying catch-up with that late enrollment penalty. So for folks who would like to avoid that late enrollment penalty box, and they want to, they're not taking prescriptions, prescription drug coverage starts in Oregon at about $13.20 per month. If it's all by itself, that standalone drug plan. If you want, you can go with a zero premium Medicare Advantage plan that has drug coverage. And now you're not paying anything, and you still are getting drug coverage. If you're not taking prescriptions, you don't have to use it. If you happen to get a prescription issued, then you could use it. So it's optional. but just keep in mind, you're going to pay more if you delay and you decide to join later. You don't pay while you're not in the plan, but you are going to pay when you do enroll in the plan. So you have to be enrolled in Medicare somehow in either A or B or both in order to be eligible for Part D. Folks who live outside of the U.S., maybe we have expats that are living in Mexico or Canada or other foreign countries. They're not living in a service area. They are not eligible either, even if they have A or B. They're not eligible for a late enrollment penalty either because they cannot have prescription coverage if they're living in a foreign country full-time. But if you are living in the U.S. and you do want to have drug coverage, we're going to take a look at how the drug program works. There are a tremendous variation in which plans cover which drugs. It's really difficult just to throw a dart at the wall and pick one. It really does depend on what medications you specifically are taking, and we use a tool called the Medicare Plan Finder on Medicare.gov to factor in all of your specific medications to find the plan that is going to cover your medications at the lowest cost. So when you are getting ready to look for a plan, this is what the Medicare Plan Finder used to look like. They've updated it just recently. And basically you're going to want to either, one, create an account, which we recommend, or if you don't want to create an account, you can look by zip code, but it's not going to save any of your information. If you create an account, it will save your information, and that way every year you can log back in, kind of do maintenance updates, see what's changed, and do the Plan Finder search again. So how you would do that is you would continue, if you don't have an account, you would continue without logging in. And let's just say, oh, this year I want to create an account. I've got 7 or 8 medications now. I don't want to keep typing those every year. I'm going to create an account, so I hit that login without creating an account, but then it gives me an opportunity to create an account. Otherwise, I can just put in my zip code, and then away I go. And then it's going to ask, what medications are you taking? What pharmacies do you like to buy from? How often do you fill them? Do you fill them 30 days, or do you fill them every 90 days? Et cetera, et cetera. And once you put all that information in, then you're going to get a whole list of plan results specific to your medication needs and your area of the country. So this slide looks a little busy, and I want to kind of point out that the color coding does have some meaning. So any prescription drug plan that is creditable, remember I used that word earlier, that means that it's as good or better than what Medicare offers, has to meet or beat this level of coverage. And we're going to walk through this pretty quickly. All Medicare Part D plans, whether it's a standalone drug plan or a Medicare Advantage plan, has to meet or beat this structure. Also, any retiree prescription drug plans that are subsidized by the federal government also have to meet or beat this structure. So Medicare says in 2020, the plan cannot have more than a $435 deductible. That's stage 1. Some of our plans have lower or no deductibles, depending upon their premium. There's kind of a teeter-totter effect. The lower the premium, the higher the deductible. The higher the premium, the lower the deductible. If your plan has a deductible and you have met that deductible with purchases, you're going to pay the first $435. Now you move into stage 2, which is called the initial benefit period. In the initial benefit period, insurance companies have contracts with certain manufacturers of certain drugs. And so they have a structure called the tier level. And every medication that they have on their formulary, their list of drugs that they cover, is assigned a certain tier level. And each tier level has an associated cost. So just in general terms, tier 1 and 2 are generics, tier 3 and 4 are brand names, tier 5 are specialty and injectables, tier 6 sometimes are those maintenance drugs that are really low cost, and they're generally zero. And in most cases, plans have at least 5 tiers. Sometimes they have that 6th tier. So depending upon where your medications fall, if it's a generic or a brand name, the company is going to have assigned an out-of-pocket cost for that particular medication. Medicare says that the plan, on average, over all of their list of drugs that they cover, has to cover 75% of the cost. Now, if you have a generic that is zero copay and you have a brand name that's 33% cost share, you're paying more than that 25% co-insurance, but on average, you're actually getting that cost share. So that's why I say on average, the plan covers 75%, and on average, you are going to have a 25% out of pocket. Once all of the value of the medications you purchase, what you pay in that yellow area and what the company pays in the blue area, yellow and blue makes green. I'm looking at that bar that says $4,020 in total value of drugs. Now you're going to leave stage 2 and you're going to go into stage 3. Stage 3 is called the coverage gap. Some people know it as the infamous donut hole. And back in 2006, the donut hole was 100% out of pocket, and folks did not like that one bit. Here they were enrolled in insurance coverage that was supposed to cover their medications. They were paying a premium, and they were still having to pay 100% out of their pocket. So the Affordable Care Act said, no, this isn't working for Medicare folks. We're going to slowly reduce that out-of-pocket cost over the next 10 years, from 2010 to 2020, until it looks like stage 2. We're going to, quote unquote, close, it's not zero, but it does close that 100% down to 25% out of pocket. In that pink square, that just says if you have a brand name drug, you're still going to pay 25% out of your pocket of whatever the insurance company is paying for it, but they're not going to shoulder the other 75%. They're actually going to get a discount from the manufacturer of that drug. And that discount acts as if it's coming out of your pocket. So you're getting credit for 95% of the cost of that brand name as if it's coming out of your pocket. And that's important, because on that very bottom line there where it says 6,350 TROOP. TROOP stands for true out of pocket, which these days is a little bit of a misnomer because 70% is coming out of the manufacturer's pocket. But needless to say, all that yellow, that's coming out of your pocket, plus that pink square, which is coming out of the manufacturer's pocket, as if it was coming out of your pocket, contributes to that orange square. Yellow and pink makes orange, and that 6,350 is a threshold. If your medications reach $6,350 out of your pocket, now you're going to leave stage 3 and you're going to go into stage 4. Stage 4 is called catastrophic coverage. When you reach stage 4, Medicare and the plans, and they contribute 95%, and you have a 5% out-of-pocket cost. 5% doesn't sound like a whole lot, but for folks who have very expensive medications, I'm thinking Humira for rheumatoid arthritis can run $4,000, $5,000, $6,000 a month. Some multiple sclerosis injections. those folks are going to get to stage 4 the first time they purchase their first prescription. If it's a $6,000 a month prescription, 5% is still $300 out of pocket. So SHIBA counselors are trained to look for ways to reduce that out-of-pocket cost. We have websites like needymeds.org that offer patient assistance programs from charitable organizations or foundations. We have manufacturer copay assistance programs or free programs for those medications. So we're very good at trying to lower those out-of-pocket costs. If you have expensive medications, please give us a call. Give us a chance to see if we can find you some savings. Some interesting fun facts to know: if you are a PERS retiree member, their standard benefit is better than what Medicare offers. They have no deductible. No prescription is ever going to cost more than $250 in copay for a 30-day supply. And if you were to have more than $6,350 in out-of-pocket costs, their insurance does not have a 5% cost share. Now, for those of you who aren't PERS eligible, I know this sounds like, boy, those PERS retirees are getting a lot. The PERS insurance premiums are quite high. So they are getting Cadillac coverage, but the premiums are Cadillac rates as well. So for some people who don't have a need and don't have expensive medications, maybe they are not willing to pay that higher premium for that coverage, and they're looking at something on the publicly available side of the equation. So we have some ways that you can look for savings. Medicare contracted insurance companies do not only have contracts with drug manufacturers, they also have certain pharmacies they do business with. Just like with my insurance company has a better price share contract with Fred Meyer and Walgreens. Some companies might have a better contract with Weimart or Rite Aid or Safeway. So it's a good idea to maybe check with your insurance company to make sure that you're using a preferred pharmacy, or check the price at a preferred pharmacy to see if it's going to offer some savings for you. Another alternative is, instead of getting 30-day fills, you might want to get 90-day fills. Oftentimes, insurance companies will give you a little discount. Maybe it's 2.5 times the copay instead of 3 of a 30-day fill, or 2. So that might be a way to save some. Or use their mail order pharmacy. Mail order pharmacies that are contracted or embedded in that prescription drug company's plan can offer some savings as well. SHIBA counselors are very good at looking at all of those factors. So again, use our services, call our call center. We're happy to look up and see if there's ways that we can offer you some savings. Just make sure you're using those contracted pharmacies so that you're getting the best value for your insurance needs. So similar to the state program that helps with the out-of-pocket costs associated with Medicare, the federal government realized, gee, not everybody's going to be able to afford to have yet another insurance program and another insurance premium. So this is called the Limited Income Subsidy, or more familiar term is Extra Help. And the Extra Help is available to anybody who meets those eligibility criteria you see on the screen. For a single person, gross monthly income of $1,615, or if you're a couple, $2,175. This program does count resources. So if you have savings, investments, anything that is liquidable, they are going to look to see if you meet the eligibility requirements of that resource. Less than $14,610 for a single person, $29,160 for a couple. What this program does is it provides assistance with prescription premiums. It does go up to $32.57 in 2020. Not all insurance plans have premiums that are that high. We have, like I said, prescription drug plans that start at $13.20. So maybe that plan would get covered in full. That would be called a benchmark plan because the subsidy is going to cover the full premium. The most that anyone would ever pay if they are eligible for the Extra Help program is 15% of whatever that company says is the full cost of the drug. And oftentimes it's much less. So if you are thinking that maybe you or somebody you know might be eligible for this program, we have Oregon Medicare Savings Connect phone number at the bottom there. It's very quick. It takes less than 10 minutes to get screened. If you are eligible, you can apply right on the telephone, and if you are eligible for state benefits, staff at that phone number will also refer you to state to get that application started as well. It's a great program. We really want folks to take advantage of it. They're leaving benefits on the table. So keep that in mind. If it's not relevant to your situation, but you have friends, families, neighbors that it might be relevant to, please let them know to call and get screened because we would love to get them enrolled. All right, so the last part we're going to talk about is the Medicare Advantage Part C plans. You might recall at the top I said these are private insurance companies. Think in terms of Providence Health, Regence, Blue Cross, Moda Health, Kaiser, that have contracted with Medicare. And because they have contracted with Medicare, they agree to Medicare's terms and conditions to provide all the same benefits that Medicare offers. Medicare says, but if you want to add additional benefits, you can do that too. So sometimes they do sweeten the deal. There's only a couple of criteria that must be met in order to be eligible to enroll in a Medicare Advantage plan. Number one, you have to be in both A and B because that's exactly what they're managing. They're managing all your hospital and your medical benefits. Number two, you have to live in that plan service area. So if I'm living in the Portland area, I have lots of different choices. If I'm living in Hermiston, I have a lot fewer choices because there's not as many plans that work out in Hermiston that work out in Portland. So it is going to be very specific to where you live by zip code of record with Medicare. And then the other thing is you have to realize that this becomes your primary insurance. You're going to get a Medicare card, a Medicare Advantage card from that insurance company, and now you show that card every time you go to the doctor and the hospital, and if you have drug coverage included, you're going to use it at your pharmacy too. Medicare rules say that if you want to have health coverage from a Medicare Advantage plan, you cannot add a standalone drug plan. If you want to have health coverage from a Medicare Advantage plan and drug coverage, you have to get it all packaged together in one bundle from one company. And that just simplifies things because they're managing all your benefits and they're keeping track of everything. The things that might be added that sweeten the deal is a lot of these plans offer preventive dental. They'll give you, as part of your package with no additional cost, cleanings, x-rays, and exams. Some other companies say, well, if you want to have that dental coverage, you're going to have to add an additional rider. And maybe it's going to be $29 a month or $30 a month extra to have that dental package. Oh, and by the way, instead of just having preventive x-rays, cleanings, and exams, maybe we'll throw in some comprehensive dental, like fillings and crowns and root canals and things like that. So it's worth taking a look to see if you want to have that type of coverage, whether or not Medicare Advantage is going to work for you in those areas. Additionally, more and more Medicare Advantage plans are offering no-fee fitness club memberships. And they have a whole list of Silver and Fit and Silver Sneakers locations that you can take advantage of those fitness club membership benefits. Or maybe you want to have glasses every couple of years. Vision benefits are pretty common. You have a copay for a routine vision check, and then you get an allowance. Oftentimes it's right around $100 every couple of years to replace or update your glasses. So Medicare Advantage plans, like I said, can offer additional benefits that original Medicare may not offer, and that might just tilt the scales in one direction or another. The other thing about Medicare Advantage plans is they take everybody. It doesn't matter if you're 65, 75, 85, 95, whether you're you have very good health or you have a lot of chronic conditions. It doesn't matter if you're a smoker or a non-smoker. They're not going to look at any of your pre-existing conditions or your health issues. They don't have what's called medical underwriting like Medigaps do. And so any given year during the time period when it's open enrollment, October 15th to December 7th, and special circumstances, you can join a Medicare Advantage plan, and everybody pays the same monthly premium with the exception of folks who might be getting some financial assistance for that drug program. Now, there is one caveat. It says, except ESRD. In 2020 is the last year that Medicare Advantage plans are not required to enroll people who have end-stage renal disease, and that is kidney failure, and they're on dialysis. But starting in 2021, that is also changing. So we will know more about the 2021 parameters when we go to our update trainings this year. I know they're getting ready to roll that out. I'm sure there's going to be some rules around that, and we will keep everybody updated in our network as to those rules. So in Oregon, we have two types of Medicare Advantage plans. We have HMOs, Health Maintenance Organizations. Predominantly, we think in terms of Kaiser. Kaiser is a closed network. You are a Kaiser member, you go to Kaiser doctors, Kaiser hospitals, Kaiser facilities. You have to get your services within that network. If you need specialty services that organization cannot address, in order to go outside of that network, you're going to need to get a referral and prior authorization. So I use my own family circumstance. My mom was a Kaiser member. She had a very serious eye issue that needed to have surgery, and Kaiser could not perform that surgery. They didn't have the specialist. So she got a referral to go to the KCI clinic. KCI clinic, because she had that referral, it was just as if she was in her Kaiser network because she would pay the same copays. It was an approved authorization to go to KCI. If my husband and I had just said, hey, we're going to take mom to get the best care, we want to take her to the KCI clinic, and we didn't have that referral, she would have paid 100% out of her pocket. So it's really worth it to explore your plan to make sure you're following whatever rules they say you have to follow. Get those prior authorizations, get those referrals so that you are able to take advantage of those services. POS stands for point of service. If your HMO has a -POS, as in the case with like Providence Health, Providence Health says, yes, you need to stay in our network, but if you need to go outside the network, number one, it has to be a Medicare contracted provider. And number two, you're going to have a much higher cost share at that point of service. So instead of your regular copay, you might have a 30% up to a 50% out-of-pocket cost associated with that point of service coverage. So keep in mind, anytime you stay in the network, it's going to be a much lower out-of-pocket cost, but you do have some benefits if you go out of the network with either POS or authorization at a much higher cost. The next type of plan we have in Oregon is called PPOs, Preferred Provider Organizations. Preferred provider organizations are just what that says. The insurance company has contracted with so many providers and they are accepting whatever that insurance company says is going to be their reimbursement rate. They are preferred. So you have a copay to go to that network of participating providers. You're not dealt out of benefits though. If you want to go outside that network of preferred providers, you can, but you're going to pay a much higher copay. The kicker here, though, is that not all providers will bill to all PPOs. The insurance company says, yeah, fine, no problem. Get them to bill to us. We'll go ahead and process the claim. But if you're a snowbird and you go down to Arizona for 3-4 months out of the year and you want to get primary care down in Arizona, Arizona doctors have no idea about Oregon Medicare Advantage plans, and they would have to have an idea of what their reimbursement is going to be. So oftentimes we'll hear, well, the doctor wouldn't accept my insurance. They made me pay out of pocket. Okay, that's fine. You can file a paper claim, but because the doctor charged you whatever his going rate is, it's not what the insurance company contracted rate is. So you're not going to get reimbursed at that full cost share. So just keep that in mind. Not all PPOs work in all areas because not all physicians are going to accept all PPOs. If you stay in the service area, there's usually no problem. If you're new to Medicare or you're new to the area and you need to have a provider, please check with the plan and your provider to make sure that the two are going to align. It does no good to enroll in a Medicare Advantage plan and then find that your provider of choice is not in their network and is not going to bill to that plan. So we're getting ready to wrap it up. How do we enroll in Medicare? Well, you can start collecting Social Security retirement benefits as early as 62. If you start collecting Social Security retirement benefits at 62, 63, or 64, Social Security thinks you're retired and they are going to automatically enroll you in the Medicare program. You're going to get your card in the mail with A and B automatically. Well, if someone is retired and collecting Social Security retirement benefits, but maybe they're married to somebody who's still working and they have their insurance benefits through that employer, they're going to need to send that card back, sign the back, and decline their Part B, saying, I have other insurance, I don't want this to start right away. But because they're collecting their retirement benefits, they're going to have Part A regardless, because A and retirement benefits are tied together at age 65 and beyond. If you're not collecting retirement benefits and you're not covered by employer group health coverage, you want to enroll in your Medicare, and you have a 7-month period in order to accomplish that before you are considered late. The 7 months starts 3 months before your 65th birth month. It includes that birthday month, and then it extends 3 months after. So 3 and 3 plus 1 is 7. And we'll take a look at a chart in the next slide. When you do get ready to enroll, you're going to need to contact Social Security somehow. You're either going to call, you're going to go visit in person, which you can't do right now because Social Security offices are not open to foot traffic, or you can go online. You're going to need to have a mysocialsecurity.gov account in order to enroll online. If you have frozen your credit, maybe you were exposed in the big Experian credit hack, you're not going to be able to create that My Social Security account. So you're probably going to have to call Social Security. Whenever you talk to Social Security, either on the phone or in person, please document good notes, because we work in a call center. We get a lot of complaints. I know our view is a little skewed. We're all human. We make mistakes, but oftentimes we find that if someone makes a mistake and it's well documented, we can get it fixed. If it's not well documented, it's almost impossible for us to get it fixed. Oh, I don't know when I called. I don't know who I talked to. I don't remember what they said or what date it was. So keep good notes. Our trainer, my trainer, back in the day has always said, tell your folks to get one of those big 5-star, 5-subject pocket spiral-bound notebooks and just write insurance across it. Everything that they get in the mail goes in those pockets. Everything that they have a conversation with, or it's a journal, that is your legal protection, and it's called equitable relief. If you have good documentation and something goes wrong, you are able to get relief from that error. If you are filing for Social Security disability, you have most often a 24-month waiting period once your payments begin before Medicare kicks in. So Medicare will kick in on the 25th month of those disability benefit payments automatically. So here's that chart I was referencing. So if your birthday, let's just say your birthday is in September, and so your birth month is the 4th month, September, and you have June, July, and August. Get a running start in order for you to have a September 1 start date. If you wait till September, now you're going to have an October 1 start date because you waited till the month that you were 65. If you wait until the months after you turn 65, now your start date is going to be pushed out even further. And the reason why I use September as my example is I had a client, her birthday was in September, she turned 65, and she had decided she was going to retire from working at the end of the year, which was December, which is her 7th month. Had she notified Social Security before December, she could have maybe picked a date that was going to work for her better. But because she was retiring, she thought she had a special circumstance. When you are in this 7-month period, this initial enrollment period, it takes precedent over any other special circumstances. So she called up Social Security in December and they said, well, you're not going to get your Medicare to start until 3 months later, which would be March 1st. And she said, but I'm stopping working. My employer group health coverage is going to end at the end of December. Well, that's the best we can do unless you want to work in January. So that's what she did. She worked in January, 1 month out of that 7-month IEP, and now she has a special enrollment because she's stopping working and she could get a February start date. So just keep in mind these timelines are very specific. Again, SHIBA counselors are really good at figuring this out. If you have questions or you just want to run it by us to make sure that you understand it correctly. That last little box down at the bottom, if your birthday falls on the first day of any month, Social Security law says you have to be eligible for Medicare for a full 24 hours prior to your birthday. So your whole time period shifts back 1 month. So my gal, if she was eligible, her birthday was September 1, she could actually get her Medicare to start August 1st because her birthday was September 1st, everything rolls back 1 month. We've covered this quite a bit if you're still working and you have employer group health coverage through active work, or if your spouse, your legal spouse is still working and they have covered you under their active work, then you can delay enrolling in Medicare. You don't even have to let Social Security know. You can enroll in Medicare, but unless you have medical needs that are going to be covered by some Medicare dollars, you're paying $145 every month for something that may not give you enough benefit to make it worth that premium. Plus, you can enroll in Medicare anytime while you have group health coverage through active work. So let's just say George blows past his 65th birthday, he's in good health, he's, you know, cruising at 68, he thinks he's going to make it to 70, and now all of a sudden he has some sort of a medical need. He can enroll in Medicare immediately, even without stopping working, because any time while you are covered under group health coverage, you can enroll in Medicare. You are going to have to prove that you have group health coverage. There's a form to be filled out by your employer, but once you have that form, you take that to Social Security, that's your ticket in. If George says, no, I don't need it right now, I'm in perfect health, I'm going to go backpack around Europe, he's got 8 full months to be on time. But, well, I'll tell you, that 8 months flies by, and if he's in A, Medicare Part A, he really only has 60 days to replace any drug coverage. So there's a lot of little nuances there. If someone missed enrolling in A or B during that 7-month timeline called the initial enrollment period, there's a general enrollment period. That rolls around every year. It's January, February, and March, but benefits are going to be delayed until July 1. If you want to enroll in a Medicare Advantage plan to go with your A and B starting July 1, you need to do that sometime before July 1. Once you get to July 1, you can't add anything till the next open enrollment period. So just keep that in mind. Again, very slight nuances to these timelines. If you are late in enrolling in Medicare, if you are subject to late enrollment penalties, then Social Security is going to inform you that you're going to pay more for those Medicare benefits. For joining Medicare Advantage plans and drug plans, there is several time periods when you can exercise your option. When you first become eligible for Medicare during that initial enrollment period, that's that 7-month timeline, you can choose what you want to add with it. Or if maybe you didn't add something right away, every fall, called the annual enrollment period, which starts on October 15th and ends on December 7th for a January 1 start date. And by and large, these are 1-year plans. So you're going to have a January 1 start date, and it's going to be a calendar year commitment. Unless you have, again, special circumstances. You're kind of locked in to that plan for that calendar year. If you start the year on January 1st in a Medicare Advantage plan, you have 3 months to change your mind. So this came about, I think, probably because we had some insurance companies that negotiate with their participating providers up until the 11th hour. And let's just say your primary care physician at the 11th hour says, no, I'm not going to take that insurance plan anymore. And here you are stuck with holding this insurance plan and you can't make a change. So now January, February, and March allows for folks who are in Medicare Advantage plans who have networks of participating providers to say, okay, I want to switch to this other company that my primary care physician is going to take, or maybe I'm just going to go back to original Medicare and have just a standalone Part D plan. So you got lots of options there. That last bullet, special enrollment periods, relates to a document that we have that's literally 14 pages long of special circumstances that might apply where we can get you into out of switch you your Medicare Advantage plan or your prescription drug plan. So way too much to go into in this training, but certainly worth a call to our office if you would like to explore that. Late enrollment penalties, we get lots of questions about these. Social Security keeps track of what you have had as far as insurance, whether you've had creditable, remember that term, creditable drug coverage, whether you were on time when you enrolled in Medicare A or B. A does not have a penalty if it's premium free. It's only when you buy Part A that you might have a late enrollment penalty. We don't see that very often. B, on the other hand, for every 12-month chunk of time that you could have been in Part B and you did not have employer group health coverage through active work, you could be assessed an additional 10%. So 23 months would only be a 10% added to your monthly premium. 24 months, that's two 12-month chunks. Now you're up to 20% added to your monthly premium. So it pays greatly to be on time and to know what these possibilities of penalty are to avoid them. For Part B, for prescriptions, they calculated it a little differently. The insurance companies are actually vested in this because they get to keep that late enrollment penalty because you were not covered by other prescription insurance. And it's calculated at 1% for every month that you did not have creditable drug coverage. And the 1% is based on what's called the National Base Beneficiary Premium. It's just the average premium for the whole United States. Right now, that average premium is $32.74. So rounding up, it's about 33 cents for every month you did not have coverage. If you did not have creditable drug coverage for 12 months, it's going to add $3.92 or $4 to your monthly premium for the rest of your Medicare life. It never goes away unless you are eligible for financial assistance. So it does, again, pay to be aware of these penalties so that you can either go into it with eyes open and realize, yes, if I ever have to have drug coverage, I know I'm going to pay more, and that's an informed decision to make, or to at least know that if you get drug coverage sooner than later, it's going to minimize any late enrollment penalties. For those of you watching that you have the Public Employees Retirement System, just be aware this is high-level information. PERS really likes to have you get your information from their office. But just the basics, you have to be eligible for a PERS pension in order to be eligible for the PERS health insurance program, PHIP. Eligibility is determined by PERS. They're kind of like the Social Security office for the PERS health insurance program. They're going to look at your years of service and your eligibility and tell you, yes, you are eligible, or no, you are not. Just like all other Medicare Advantage programs and Medicare supplement programs, you have to have A and B. So the first step is going to be to enroll in A and B, and PERS wants you to do that sooner than later. They don't want you to have any lapse in coverage between stopping working or coverage through a working spouse before you get onto the PERS health insurance program. So making sure that you have that continuous health coverage is really critical. I've seen folks dealt out of that benefit because they did not maintain continuous health coverage. The nice thing about the PERS health insurance program is it's group coverage. So you can have dependents, spouses, and children up to age 26. You can add a very nice dental option when you first enroll. You cannot add it later, but you can enroll when you first come on. All of their plans do include drug coverage, including that Medicare supplement policy. So that makes it a little different than what's available on the open market. You get to change plans from what within their offerings every year. No underwriting, no pre-existing exclusions. And they do have the one supplement through MODA, and they have 4 companies that offer Medicare Advantage managed care, which is Kaiser, Providence, United Healthcare, and Pacific Source, depending upon where you live in Oregon or out of Oregon. So the MODA supplement and the United Healthcare are national. PERS has an excellent, very user-friendly website. I encourage you to go check out pershealth.com. Some of our SHIBA counselors are PERS retirees, so if you wanted to have a chat with one of those PERS retirees about their coverage and their benefits, you could certainly ask specifically to talk to a SHIBA counselor with that experience. Otherwise, there's the phone number. You can call PERS and get specific information for your situation at that office. For those of you who are federal retirees, you are in a very unique group. Federal programs do not compete with each other. So Medicare is federal, and federal retirees have insurance through their retiree plan. They're not required to enroll in Medicare if they don't want to. Their retiree plan will work just like it did while they were an employee, and they'll have all the same deductibles and out-of-pocket costs, et cetera, and premiums. If they do enroll in Medicare, oftentimes those retiree plans will eliminate those co-pays and deductibles because now someone has additional health insurance that is help paying for those medical services. So good to talk to a SHIBA counselor. We do have federal retirees in our ranks and learn exactly how that might work for you. One other very unique situation to the federal folks is if you decide you want to go look at something that is publicly available and outside of your retiree options, as long as you have both A and B, you can suspend your federal health benefits and go try a Medicare Advantage plan. If it doesn't work out the way you hoped, you can unsuspend and go back to your federal retiree benefits. That is very unique. I do not know of any other retiree plan that allows folks to leave and come back. Anytime you leave a retiree plan, most often that door closes forever and you never get a second chance. So be very, very careful when choosing to leave a retiree plan, and make sure you have all of your facts in writing in case something does go awry. Every year, federal folks do have an opportunity to look at all the different plan offerings, and they can make a change during their open season, which kind of coincides with deer season. This year it's November 12th to December 7th, and then again you're locked in for that 12-month period calendar year. You can always leave, but you can't always get back in. And their website for their program and plan information is opm.gov. Wrapping this up, final thoughts. Start getting your information early. Kudos to you for listening to this whole presentation. This is really important decision making that you're going to have to come to some terms, and having a good foundation and a good knowledge of how these programs work is going to be in your best interest. An informed decision is going to be a much better way to go than to talk to friends and family whose situation may be completely different than what your situation is. Every person is unique, so knowing what your unique situation is going to be in your best interest. Get your information from an official source. Like SHIBA, we are here to be your local resource for accurate and timely Medicare information, or talk to a federal employee. SSA, Social Security, is strictly about getting eligible for and enrolled in. It does not have anything to do with the actual benefits. Medicare, on the other hand, Centers for Medicare and Medicaid Services, that's a good resource for talking about what your benefits are, what your co-pays are, if something is covered or not. All of those things are going to be much better through Medicare. Social Security doesn't know about those benefit packages. Anytime you're talking to a federal employee, you have federal protection, but it's good to document no matter who you're talking to, whether it's a SHIBA counselor or an insurance company representative. Document as much as you can because that does provide you some protection if you have an issue and it needs to be resolved, and we can help with that. And then obviously take advantage of the free counseling program. Right now we're counseling via telephone or via Skype because of the COVID-19 situation. Hopefully we'll be able to resume in-person counseling later this year, and we would love to have you take advantage of our services and get you as much information as you possibly could use. And with that, I will say thank you for participating. We really appreciate your time, and I hope this has been of value. Take care.